So, non-steroidal anti-asthma agents. Anybody know anybody that's on these? Okay.
Not off the top of my head, no.
All right. So you've got the cromolyn-like drugs. I had talked about that a long time ago, so I'm glad we're tying it all in. That's a mast cell stabilizer. So if you guys remember about the inflammatory process, that mast cell is what the IgE attaches to and starts having it disperse the histamines. You've got the anti-leukotrienes and the monoclonal antibodies. So clinical indications for these guys, it's prophylactic only. You have the SABAs and the LABAs and the LAMAs, all of those designed for helping with the bronchospasms. And then you've got the steroids that are for mediating the inflammation. And then these are totally prophylactic, and it's trying to stabilize the mast cell or stop it from releasing before it gets to the point of releasing those leukotrienes. Again, going back to that asthma step plan, step 2 would be a good time to implement it if you believe that it is not going to respond to other therapies or if it is a chronic kind of condition. So identification of them, these are the ones that you're going to want to put on your drug cards. We're going to go over them a little bit. Okay, so we've already identified that asthma is a chronic inflammatory disorder. You've got extrinsic and intrinsic. Extrinsic is the allergic one. That is the one that you are going to be dealing with the IgE antibodies. It's a response to an allergen that has then sensitized your body. Everybody's coming in now. Morning, morning.
Good morning.
All right. Intrinsic shows no evidence of an initial hypersensitivity reaction to it, so that it shows no indication that a antibody has been established. 3 components, talked about that. Acute asthma attack, hyperresponsiveness of airway to various stimuli. They used to call that reactive airway disease. I think every couple years they change the wording of it. And then you've got the persistent inflammation that becomes worse. That's that cycle of catch-22, or just continuing that. As long as you have the inflammation, you're going to have the bronchospasms, you're going to have the histamine cascade, the inflammatory process, and then the narrowing of the airways. So it just becomes a vicious cycle. Here's a nice visual. You've got the antigen. There you've got your normal response here. Your lymph system kicks in. It recognizes that it's an antigen. It creates your IgE, which then attaches to the mast cells in preparation for any additional exposure. And all of a sudden you have an exposure. Good morning, Justin. Again, to that antigen. It gets attracted to that IgE. It activates the mast cell, which starts that whole process. The process, you're going to have the histamine release, which causes the bronchospasm, the leukotrienes, which is the huge portion of the inflammatory process. So you're going to have the smooth muscle constriction, mucus hypersecretion, dilation of the blood vessels, and tissue edema. Clinical result of asthma, chronic persistent airway, occasional acute episodes of wheezing, airway obstruction, mucosal swelling, mucus secretion. Here's a really good visual of it. I can't remember if I had put that on my last slide or not, but it never hurts to reiterate it. So you've got the sensitization phase, then you've got the early phase, late phase, and then chronic. Mechanism of action, again, an allergic response. Did you guys have a chance to watch the inflammatory video that I had put up? Really gives you a good visualization of all of the different processes in that inflammatory response. So again, involves the mast cells, IgE. You've got the mast cell releases the leukotrienes, the prostaglandins, proteinases, histamines, platelet activating factor, and cytokines. Visualization. So antigen, T cell, more specifically the TH, helper 2, that in turn results in the release of the interleukin 4 and 5. That gets that B cell to establish the IgE, which again attaches to the mast cell. Then you've got the T cell also releasing the IL-3 and the GM-CSF, or CSF, which gets those eosinophils going. That's going to start your blood vessel leaking and the inflammatory of increasing the blood vessel perfusion and then permeability. Neutrophils, same thing. Non-specific for asthma, the intrinsic has this exact same response. It just doesn't deal with the IgE. It has a specific pathogen, or what did they call that? Particle, which triggers from the mucus gland secretion. Then you've got, again, the blood vessel leakage and the smooth muscle constriction. All of those have the side effect of stimulating the parasympathetic system with the bronchoconstriction. So cromolyn, mast cell stabilizing agent. The dosage, I'm not going to go into all of those. We've got the drug card information that I gave you. But administration, you can do SVN, you can do MDI. There's also a nasal solution. Mode of action is going to be on the next slide. And side effects, again, reference your drug cards. So mode of action of the cromolyn. You've got the antigen, antibody formation, antibody attaches to the mast cell, then the re-exposure. What cromolyn does is it hits right here and it stops, it stabilizes the mast cells so it does not degranulate and get and open up and, what's the word I'm looking for? Release the histamines. So Clinical efficacy, it blocks more the late stage reaction in asthma. Also has some anti-sickle cell effects, so it reduces the sickling of the red blood cells. Clinical application, usual dose is 20, but it's prophylactic only. So the biggest thing with all of these therapies that we're talking about is that it is not a rescue inhaler. It has nothing to do with bronchodilation. It is prophylactic, no bronchodilation action. So, anti-leukotriene agents. Leukotrienes, again, with the inflammation. They are also potent bronchoconstrictors and stimulate other cells to cause, we just talked about it, airway edema, the mucus secretion. It also affects and inhibits the ciliary beat, recruitment of other inflammatory cells. Leukotriene production is a result of stimulus of the immune system. So we don't have leukotrienes just sitting in our cells waiting to be released or having something to release them. They're actually a part of a cascade where they are produced once the inflammatory process has been initiated. View of it, visual. I'm a visual kind of person. So you've got the stimulus, which here is what we are dealing with quite a bit, is the phospholipase A2, which starts that arachidonate. So sorry, I hate these words, but it starts this inflammatory cascade that breaks down into three main parts. You've got the lipooxygenase, which gets the leukotriene started. You've got the COX2 and the COX1. Those are all cellular oxidants as well. This releases the prostaglandins. This one, does the inflammatory response with the vasodilation. Here, the leukotrienes, the ones that we are concerned about, are attaching to the receptors, the cis-LT1 receptor. Leukotriene B4 does the chemotaxis, inflammatory process again. Leukotriene C4 and D4 does bronchoconstriction. I'm going to show you a video in a minute that helps tie all that together. Anti-leukotriene agents, you've got Zyflow or Zyflow extended release. It's oral or enteral. It inhibits the 5-low enzyme, which stops the progression and formation of the leukotrienes. Going to show you that as well in a following slide. Hazards and side effects interact with theophylline and warfarin. Then you've got Accolade. It also is oral. It is a leukotriene receptor antagonist. What does antagonist mean again?
It aggravates or initiates?
That's an agonist. Antagonist is a blocker.
The block. Thank you.
You're welcome. And then hazards and side effects. Headache, respiratory infection for almost all of these agents, but it doesn't go into why it causes it. I would just imagine that it is something that's already established in their airway as being a chronic condition, so they are more prone to infections. Nausea, diarrhea, pain. Okay, Singulair. Singulair is also oral. Mode of action for that is, again, a leukotriene receptor antagonist. It binds with high affinity to that CSSLT1 receptor subtype. The other thing that they use Singular for is allergies, which works really well. All right, so here's the leukotriene pathophysiology.
Watch carefully.
Okay,
Now we will go through the other pathway of arachidonic acid metabolism,
there you go.
which produces leukotrienes. Icosanoid production starts from the phospholipid bilayer of the cell membrane, where phospholipase A2 catalyzes the release of arachidonic acid from the phospholipid molecules. This 20-carbon polyunsaturated fatty is the main source for all biological icosanoids. Arachidonic acid can be engaged in either prostaglandins and prostacyclin or leukotriene production pathways, which are started by the action of 5-lipooxygenase enzyme to produce intermediate 5-HPETE, which is further modified by the same 5-lipooxygenase enzyme to produce leukotriene A4. LTA4 gives rise to either LTB4, LTC4, LTD4, or LTDE4. Then these leukotrienes bind to the cellular receptors to induce various biological effects. Note that the number 4 in all leukotrienes refers to the number of double bonds in the main scaffolding of leukotriene molecules. Indeed, leukotrienes play a wide range of biological roles. They are important inflammatory mediators, as they enhance inflammatory neutrophil recruitment and extravasation, and increase vascular leakage. Additionally, they play negative roles in bronchial asthma, as they induce bronchoconstriction and stimulate mucus production and accumulation in respiratory pathways. Going to leukotriene pathways, you will notice that the drug Xoluton interferes with 5-lipooxygenase enzyme, thus inhibiting the production of all inflammatory leukotrienes. Finally, Zefilucas and Montelukast drugs are selective competitive inhibitors of leukotrienes C4, D4, and E4 receptors. This video was narrated by Alex.
Another way to look at it, or another visualization, and this one is in the book. So here's that 5-low, and Zyflow is the one that nips it in the bud right here, and it catches it right after the that cascade, arachidonic. There you go. So that one stops it here. Then the AST ending ones are the anti-leukotrinic. That gets stopped right before it goes to the receptor. Again, to stop the any of the cascade from hitting the receptor cells. So, role of the anti-leukotriene drugs: protection against the triggers. So exercise induced with the cooling and drying, that is enough of an irritant to cause the leukotrienes to be produced. Aspirin induced, NSAIDs can cause an increase in LTC4, and then again the allergen induced. It doesn't work as well on the allergen induced asthma, but it does block some early and late phase responses. So for chronic persistent asthma, they're determining that it's only about 50% effective, and they have no way of knowing. There's no understanding of which makes it work for what people. anti-leukotrienes in relation to corticosteroids. So number one for anti-inflammatory treatment is by far, hands down, are steroids. However, it can be used together with it and have an additive effect. And anti-leukotrienes are used for RSV because the body's response to RSV is very similar to an allergic response in asthma. Advantages and disadvantages: oral administration, easy, possibly once a day, very few side effects. Additive may reduce the steroid use and prevent an increase in the steroid dose. They also have it for the singular. They've got it in a pediatric dosing with a chewable tablet. Disadvantages: anti-inflammatory action is limited. Unknown long-term toxicity. Again, variable response, effective in about 50 to 70% of the patients. No predictor of the patients who will respond. It is a systemic drug, and it's not useful as a monotherapy, so it's always used in conjunction with another therapy. Then we have the monoclonal antibodies. This treatment is designed, they have narrowed it down and found the specific antibody to target. And it stops the mode of action, it stops the antibody from hitting the mast cell. It just kind of blocks it. Hazard and side effects: anaphylaxis. Can anybody tell me what anaphylaxis is?
It's when you experience bronchoconstriction, and it's an allergic reaction, but it's bronchoconstriction, and then eventually it's death.
Yeah, anaphylaxis, absolutely. Anaphylaxis is a life-threatening allergic response. So kind of a pretty severe side effect for it. So you definitely want to monitor your patient, make sure that they're not showing any signs of allergy or adverse reaction to it. And then the role of, don't make me say it, in asthma management is for uncontrolled moderate to severe asthma. As always with our assessment, evaluate the patient for appropriate delivery and the correct formulation. Make sure that they are using the appropriate device. So like for children, you want to make sure that you're not giving them a mouthpiece when you are delivering an SVN. The same as for children here. You're not going to be giving them under 5 an oral tablet to swallow, so you're going to be delivering the chewable tablets. Make sure that you know that it is not a rescue agent. Use of peak flow meter. Again, that's a good way to evaluate where you are on the asthma process and what plan that they should be in. Long term, you're evaluating the severity of their symptoms. Are they all decreasing? That's the whole goal. If you're decreasing it, if they're able to maintain a normal lifestyle without modifications, then that is the goal of asthma management. And then monitor for side effects. And that is it. Do you have any questions on the anti-steroidal?
Did you post the PowerPoint at all?
You know what? I'm not sure if I did, but I will be happy to.
If you can, that'd be awesome.
Yeah, you got it. So let's go. I'm going to go over here. All right, so objectives again, quiz, do. Here's the case study. The initial chapter 12. Oh. Hi, Jessica. The initial chapter 12 team assignment. Have you guys had a chance to look at it?
No.
No.
All right. So here it is here. I wrote down a rubric to help all of us with what's expected of it, but the group discussion down now into two groups. Sorry, just had to mute a mic. I've got you broken down into two groups. You still, on the top of the case study, or when you click on it, it's going to give you questions that are all based on the chapter 12, but the case study is different. You've got one that is chapter 12, and you've got one that's still covering a little bit of chapter 11, just to give you a variation. And then we're going to try to go over it in class. So you've got the points are 1 point per workbook question, 2 points per case study question, and 2 points per peer review. And then when you go in there, you will have an option to click on that rubric and it'll go more specifically. But the case study question, basically you have 1 point for your answer, 1 point for your source reference. Same for the peer review. And then when you get it, it will say those who are assigned to case study 1, click here for your assignment. For case study 2, click here. That way you don't have to, you'll be able to see it without having to put a reply, and you can put it up on another screen, or you can download it, or whatever you want to do with that. And then again, after it closes, you'll be assigned one peer to review, and you've got 2 days to do that peer review. So it's still a total of 7 days total, but 5 for the first one and then 2 for your review. You guys have any questions on that?
No.
No questions? All right. How are you guys doing with navigating with these? Is it getting easier? Am I getting clearer on where the stuff is to find? Being able to communicate with each other? You know that when you go into the case studies and into whatever group that you are into, that this whole side here is all yours. It's only that for your group. So you can do announcements to each other. You can create your own pages. You can see the people that are in your group. Obviously, your discussion. I'll pin it up to the top so it's the first thing that you see. You can even upload your own files. You can have your own conferences or collaborations. So feel free again to play with that. Once you get into your specific case study, trying to get out of it, if you click up on the top here where it says case study 1, that'll then bring you to this one, and you click on this and you go back to the main group. Any questions? Anything you need a review on?
No.
Okay, so once I save my, once I get out of the case study, would it save on its own?
Yes.
Yes.
Anything in the discussions, as soon as you hit post reply,
Oh, okay.
it is immediately
Okay.
in there.
Okay, I don't think I hit that last time. Okay.
That's what I was thinking too. And I've had that happen to me when I was doing the grading, and I was going back and forth between some, and then I went back in and I'm like, all of my notes are gone. So have to hit post or it will not save.
Okay.
All right.
Thank you.
You're very welcome. Since we've got a little bit of time, I'm going to go back into the discussions. Let's see. Is this different than Rachel's group? Yeah, it is. All right. So all right, who do I have here? Anybody from this group on? Heather. Oh, Valeria, you're here. Is Heather here? And Heather's here. Valeria and Heather, you guys did an outstanding job with your peer reviews and your case studies. So just wanted to show everybody what it looks like and give them a really good idea of how to continue while we're doing these. So let me get back into the discussion as soon as I get my mouse going. Valeria, you want to talk a little bit about what you put down for yours?
Yeah. So actually, Heather and I were actually just texting each other and figuring it out together.
Ah,
So I think it helped that we had each other to bounce back off.
there you go.
But I used the asthma thing that you posted. I think that helped a lot.
Yeah. And you had written down here even more specific. You know, you had said about it being the most effective medication for long term. You even went over and above and talked about the fact that since they are inhaled, they go right to the lungs. Then on the case study, obviously you can tell that you had gone to that asthma guideline. Low dose steroid. Budesonide was definitely one of them. QVAR was another. Went up. You didn't specify, which you didn't have to, that he went up into, but I think Heather might have, that he went up into step 4. So you switched him over to the budesonide and the LABA. You even added a video to make sure that the patient knew how to use the drug and the administration of it. Then she put down the reference. Heather, anything to add?
Um, I don't think so. Let me see.
So you actually you took him to a step 3, which was fine because it said go to 3 or 4. You even put down the therapeutic effects.
Yeah, I used the drug cards from the online book, which really helped. And then I looked up some of the drugs on like the drug websites,
Yeah.
which do like cool videos and stuff. So that kind of helped me understand more.
And then you also put your source down.
Yes.
So does anybody have any questions or comments on that? Does this help you with the format? And even if you guys do not have, thank you very, very much, both Heather and Valeria. Even if you don't have or you're not texting back and forth with each other, again, remembering that you guys can have a completely separate discussion here and just talk back and forth, and that's just between you guys. You can use any of these to discuss how you're going to attack it or what information that you got. All right, guys. And then again, you just hit that key up on top until you get back to the main page.
I have a question, Ms. Deaver.
Go ahead, Betsy.
Okay, so I'm looking at the objectives and agenda for this week, and I'm just a little confused because it says like the review of case study 11 today, and then the chapter 11 quiz, but then below that, it says due on the 25th, initial chapter 12 assignment due, and then the peer review is due Monday. So does that just mean the case study is due? Are they two different things?
No, they're not two different things. Yeah, it's just the case study.
Okay, so is that going to be, so basically we have till the 26th to do it, the assignment, but then we're peer reviewing. Is it due later?
Yeah, within 2 days. So let's go
Okay.
back to, good question. And actually, I think you're right. Since is the 25th
Saturday.
I always
So
lose my
Saturday is the 25th.
All right. So assignments. So let me fix that because here I changed it and I extended it to the 26th. I'm trying to give you guys enough time to do it. I really am hoping to be able to go over it on the following Monday. If I can't do that, then I'll do the Wednesday. So again, I'll change the due date for it to the 26th, not the 25th. The sooner you get it done, the easier it will be for you guys to have time to do the peer reviews. Peer reviews, you will not get an email on it until it closes, though. So
Okay.
we can decide. Do you guys all want the due date to be the 25th or the 26th?
26 would be great.
26.
Okay. So I will change it to the 26th, and then again, once it closes, you'll be assigned the peer review. Peer review must be completed in 2 days, so by midnight on Tuesday, 4/28.
Okay. I had another thing to add. Sorry.
Go for it.
Okay, so I took the quiz for chapter 11 this morning, and I just wanted to mention that there's 2 questions that don't really have a question. So I got them wrong. The question 13 and question 2, they both just, like, one of them, I can't show it to you or else I would, but it just
Right.
says,
Oh, it's okay. I can look at yours specifically because it's pulled from a test bank that I
Okay.
had to create and translate and have it upload. So
Okay.
what you're bringing to my attention is a problem in that translation.
Okay.
So I will fix that and give you credit for those. And thank you for bringing that to my attention so other people can have that.
Yeah.
So should we hold off on taking the quiz until that's fixed, or?
I'm going to do it as soon as I get out of class. So maybe give me 5-10 minutes.
Okay.
Yeah, I had the same problem too this morning when I took it.
Which one?
I want to say it was the first question I had, and I think it was either 13 or 14. I can't remember.
Okay, I'll take a look.
Thank you.
You're very welcome, guys. All right, so we're getting out a little bit early today, which is fine
Okay.
because you've got a lot of off class time work to do. So, and again, if you guys are having any problems directly following this class, I open up my office hours. So you're more than welcome to come on in and chat with me.
Perfect. Thank you.
You're very welcome. Have a good rest of your day, guys.
Me too. And don't forget to upload the PowerPoint for me, please.
Let me write that note down. Thanks, Jen.
Thank you. All right, bye-bye.
Welcome. Bye-bye.